give out the outpatient with it, so hopefully I'm doing an okay job of not confusing you guys too much. But what I really want you to walk away with in the emergency department is do your HINTS exam, get the goggles on patients, document well. I think it's central. Don't forget coordination testing and your myotomes and your BTRs. Educating the patient, if it's a neuritis, this will get better. Don't cocoon. Walk. Progress your walking as able. Stay safe. Do the VOR ×1. Educating the doctor on, okay, maybe some prednisone if you're up for that. If they're pre-diabetic, they're probably not going to prescribe it. It's up to them. And then educating the patient to getting off the meclizine as soon as they can, and then getting into outpatient expediting. And that's kind of it in a nutshell. Tons of gray zone in there though. So if you talk to me about every case that you want, you talk to each other, you talk to the therapists who are a little more experienced. Love how much you guys buddy up and you talk to each other about this stuff. That's the culture we want here. You feel supported. I think you all have my cell phone number, right? You have my cell phone number? Mm-hmm. So, I mean, I've taken calls at the most inopportune times. I'm like, I'm turning the music off or the movie off, Anthony, and I'll turn it off. If I'm with him on a day off, I'll answer the phone. And I know this is a work call, so call me anytime. But if there's somebody right next to you who you feel confident with, talk through the cases. The more you talk through the gray cases, the easier they get to, and we can't go through everything in one afternoon, one chunk. So this is just the beginning of like getting the concrete stuff and then progressing. Okay, so let's go to BPPV now. It is the most common vestibular disorder. Very common. I think a nice thing to, a nice little stat to keep in mind is 50% of all humans will experience BPPV at some point over the age of 65. So it is very common. It is 10% of the general population, 2 times females more than males, and the older we get, the more common it is, but I've certainly had people in their 20s and 30s and 40s with this. So very common, be on the lookout for it. And a lot of doctors kind of poo-poo this, you know, they're just like, well, you have this BPPV problem, just go home, try the Epley, it's on YouTube, and they've got bigger fish to fry. They've got all the other chronic disease stuff to manage. But it is strongly linked to reduced ADLs, falls, depression, and 86% have interrupted activities of daily living or work lost, and they can also, people can fall from this and potentially hit their head and have a large event or potentially die. So not so benign. There was a talk on this, this German narcissist, he was a neurologist, he was like, I want to ask the whole group here, who thinks we should get rid of the word benign? And nobody raised their hands because his whole point was this can be a very malicious problem, but he thinks we should rename it. And I was like, I actually like educating my patients that the B is for benign. This is not hurting your brain. This is not a degenerative condition that's eating away at your nerve or your brain. It's not hurting your eyes. It's annoying. But you have to be careful with movement. But it is not anything going on in your brain. So take that to heart and don't, this is self-limiting. So be careful with movement, but go to Europe. Go to your son's, wedding. Just keep staying active with it. And people get very scared over this, very anxious, so we want just to frame it that it is a benign problem. The classic presentation is spinning vertigo. But the more evidence on this is coming out, we're seeing that the spinning, so when you're trying to get at a patient, what are your symptoms? Is it lightheaded? Is it spinning? Is it woozy? Is it disequilibrium? Is it? It doesn't necessarily really matter. So I think I said this to you guys last time. I usually say there are 3 categories of dizziness. The first is vertigo. That has a true definition. It's the illusion of movement. Do you have any sort of spinning in your vision or in your body? Like you feel like there's an illusion of movement. That's vertigo. The second is not vertigo, dizziness. Some people describe it as lightheadedness, wooziness, for example. There's a million descriptors, but there's no spinning. There's no false illusion of movement. It's more dizzy in the head. Number 3, disequilibrium, like you can't quite find center. You're feeling like you're being pulled one direction or another. Do you have any of those types of dizziness, or do they blend together? Do you describe it any other way? And most often, people can say, I have 1 and 2. I have 2 and 3. and then they might give me some additional information, but it doesn't even really matter. It's a general guide to help you. So especially in the elderly, even if they don't have classic spinning vertigo, if they have any sort of temporal dizziness, it comes and it goes. Especially with head movement, you're checking them for BPPV, even if it's not classic spinning vertigo. But the classic complaints are, and there's even a questionnaire on this, lying down and sitting up, rolling in bed, maybe towards one side, bending over or looking up. If you can memorize those positions, you have a patient who just yaps and yaps and they're not giving you good information, okay. Do you have any of your symptoms with lying down or sitting up? Bending down to put socks and shoes on, tipping your head back to put your eye drops in, or washing your hair in the shower, or rolling in bed. Any of those cause your symptoms? It doesn't have to be, it doesn't matter, your symptoms. And if they say yes, your prevalence of BPPV goes up, your suspicion goes up, and you're definitely gonna make sure you check for it.
And sensation of being pulled towards one side, is
Right.
that disequilibrium?
That could be, I would document that as disequilibrium.
Okay.
And when I'm talking to that patient, I might say, does it bring on your disequilibrium? Or we'll just call it your dizziness. Does it bring on your dizziness when you roll in bed? And that's a really nice way of not making them feel like they have to fit into our categories. You're allowing them to just have their own subjective complaint. It's more of what positions, what movements bring it on.
Can I ask a question? Just based on your experience, explaining this or trying to find the most basic language to use with a second English speaker patient, what would you recommend? 'Cause sometimes I feel like that's harder. Just
Yeah, I always start with 3 categories.
Okay.
And if that's not getting me anywhere, I just say, tell me what your dizziness feels like. I don't know, dizzy. That's all. We're gonna say, and I usually say dizziness, difficulty describing in parentheses, just so I know that I tried.
Okay.
And it happens a lot. And the more experience you get with it, the less frustrated you get. It's like, all right, we'll just call it what it is.
I'm dizzy.
Okay,
I've
what
seen
type
it.
of thing?
Don't
Pain.
move your head.
So classically, once the episode is over, which is usually short, seconds to about a minute, maybe 2 minutes if it's a cupulolithiasis, usually triggered in changes of head position. And it usually is short and it usually resolves in between episodes. So that's your slam dunk classic presentation. And you might get this a handful of times. Most patients don't fit into the classic, but when it does, it's really nice usually, and it can be more manageable. This is what it should classically sound like. Okay, so we test it with the Dix-Hallpike position and the roll test, which we'll get into the basics of that, the details of how to do that. Remember, the Epley is not the Dix-Hallpike, and the Dix-Hallpike is not the Epley. The Dix-Hallpike is the testing position. The Epley is the exercise, because I hear a lot of therapists kind of mixing up the language there. Okay,
Did
so.
you do the loaded Dix-Hallpike, like MedBridge was just talking about?
Yeah,
that.
so I've incorporated that into my practice if I'm hunting. If a patient fits this description, and I test them in the Dix-Hallpike, bilaterally, nothing. Test them in the roll test, nothing. Okay, you said your dizziness comes on when you go from lying down to sitting up quickly, so let's do that. Do it quickly. I've already checked orthostatics, right? This sounds like BPPV. They get up quickly, nothing. Let me do a loaded Dix-Hallpike. I'm hunting. Also do a head hanging test, where you come straight back into supine, and the head is just in a straight plane of motion. I forget, did he talk about that head hanging test?
No.
Okay, it's a little bit more to try to tease out anterior canal.
Okay.
He's not a big proponent of the anterior canal.
Right.
Yeah.
So on this slide, anterior canal 1 to 21%, and Jeff and a lot of other experts in this say it doesn't even exist, or it's extremely rare. I can't say that I have seen it more than twice what I thought was for sure. But I don't even know for sure. Maybe I was looking at posterior canal on the other side and I missed it, I'm not sure. But by and large, the posterior canal is the most common, 80 to 95%. So the posterior canal sits right in line with your earlobe. Okay, that's the orientation of it, and the horizontal canal sits in that horizontal plane, tipped up 30 degrees. And the anterior canal sits in the sagittal plane. Horizontal canal is written up as 5 to 27%. I see it almost every day. I feel like it's way more common than 27%. But if you don't have the goggles frequently, you don't see it. And I know this because I worked here for probably 3 years before I was able to convince Michael to get the goggles. So I had to really switch from when I was at NYU, okay, we did it all with the goggles, to then here, no goggles. I had 3 years of experience without them, and then I finally got the goggles. I was like, oh, thank God. You cannot complete a vestibular exam without putting a pair of goggles on. If you're in the emergency department, you didn't expect it, and you don't have time to go up and get it, I completely understand. But if you have a known vestibular patient, you have to have the goggles with you. Okay, so the Dix-Hall pike position, we're gonna be turning the head 45 degrees towards the side that you're testing, and then having the patient lie down essentially on that here. So this guy is in a pretty nice position here, his back is pretty straight. This is a little awkward. What I don't wanna see.
We can move it over there if you
Yeah.
want.
Let me go through it when we do the lab part. So let me just talk now, and then every time I do this, I gotta do it a little differently, sorry. Depends on the room setup. So this is the left Dix-Hall pike position. The left ear is the gravity dependent ear. It's down on the pillow. You keep a patient down here for 30 seconds, maybe up to a minute, but 30 seconds at minimum, and you're checking for nystagmus. And you're coaching a patient to keep their eyes open. If they have cervical complaints, you need to twist their torso a little bit. We need to get a little bit creative in the emergency department or in the hospital. I actually really like treating in the hospital because all I do is Trendelenburg bed. So, and I'll do it even if a patient had any musculoskeletal complaints from the torso up, and they're not very mobile or they're very heavy. All you gotta do is they're sitting up here on the bed, you just position them on, let's say, okay, the left Dix-Hall pike, you put pillows under their butt and under their shoulders, and then they just go, zzz, they don't have to move at all. And eventually they get down into that 30-degree head hanging position, and they're very comfortable on the pillow. So it's actually quite nice in the hospital beds. It's harder sometimes on our outpatient beds to get them into these positions. And even the ED gurneys, they're not the easiest, but you can get there, and they all Trendelenburg. So don't be scared to do these positions in the hospital. Contraindications for the Dix-Hall pike position. So cervical instability. So who of your elderly people are you most likely to see with cervical instability? What other comorbidity might they have? RA, yeah. So that would be the one that we're gonna look out for the most. It doesn't mean you can't do this on an RA patient, you just have to know how to do your upper cervical ligamentous testing. We go over this in the fellowship pretty thoroughly. If anybody wants some handling skills with it, we can do that offline for those of you who have not been through the fellowship. So we need to be testing transverse ligament and alar ligaments in RA patients. And of course, anybody who comes in after a motor vehicle accident and they want you to see them because they're dizzy, let's say, we want to make sure we're checking those upper cervical ligaments, and we're following the Canadian C-spine rules. So Canadian C-spine rules, if they can't turn their head more than how many degrees? 30. So if they can't turn their head more than 30 degrees and they haven't been walking, then they need an x-ray before you see them. And there's other variations in there, like speed and fall from the height of a ladder, it's like 6 feet and
Direct
6
impact
feet
on
over.
head.
What's that?
Direct impact on head.
I didn't hear you.
Direct impact on head.
Direct impact
Like
on
axial
head.
loading.
So be on the lookout for cervical instability. You're not going to see it often, but be careful with your RA patients. Acute neck trauma kind of falls into that, what we're just talking about. Cervical disc prolapse, Chiari malformation. This is a little bit controversial. If they have, so with Chiari malformation, if there's more than 4 millimeter herniation, then they might need a decompression. But a lot, like Jessica Bailey has a 12 millimeter, and they're like, this is not causing all your dizziness. And they're not doing a decompression on her, and she's got a lot of strange symptoms. So I think a lot of it depends on the neurologist. But if you do have a patient with a known Chiari malformation, you might want to do a modified Dix-Hall pike, which is just like the sideline test. You just basically have the patient lie on their side, and their left ear is down, and that's kind of like the left Dix-Hall pike, so that they're not in that twisted and head-hanging gravity-dependent position. Presence of a shunt is a big one. You'd see this more over in rehab, really, than on our side, but it is possible, but that's a strict contraindication. And then certain vascular problems such as carotid sinus syncope, vascular dissection, and a known VVI. If the patient doesn't, if we don't know if they had a VBI or not, it's really, that's a gray zone, that's a hard call. So you're going a little bit more on your clinical suspicion. So a VBI is usually gonna have much more profound symptoms than just positional dizziness with certain head movements. You're gonna be getting a lot more of facial symptoms, probably pain back here, terrible headache, maybe diffuse weakness on one side, kind of depends on what stage they are in the insufficiency. But it's a bigger picture. If you feel suspicious of this at all, you're gonna be asking for maybe a CT or an MRA of their vascular structures if VBI is in your suspicion. And then maybe don't do a Dix Hallpike just then. Okay, so we were just talking about in a hospital setting, just using the Trendelenburg bed, this is what this slide is for.
We're just getting that in shape.
I don't remember, I just lectured a long time ago. Okay.
Brilliant.
So, in the vestibular system, the posterior and anterior canals are hooked up to more oblique retinal musculature. I have to picture this somewhere. Show you that later. Okay, so the musculature that in particular the posterior canals is hooked up to is oblique on these planes, and they're either inferior or superior. So what you're gonna see when the crystals move in the canal and they stimulate the receptor site, are those muscles literally contracting because the brain thinks the head moved and that they should move the eyes. It was false information coming from the free-floating otoconia. So the muscles contract. So you see, because of the line of Holt, you see a torsion and a lift from the posterior canal. So we call it, so if I put the patient in a left Dix Hallpike position, you'd see left torsional upbeating nystagmus. So it's named for the quick phase, and it's named towards the ear that's in the dependent position. So if it's a positive left posterior canal Dix Hallpike test, you're gonna be seeing left torsional, comma, upbeating nystagmus. That's how we document it. So this is the a chart that's on the bed over there. I have a bunch of laminated pictures, and I need to just put it into a booklet. I was telling them, well, I have two booklets, one an inpatient, one an outpatient, and somehow they all recently disappeared. So I have them all printed out and laminated, I just haven't stapled them together, put them in a binder again. But there's an algorithm here that is in the drawer. So if you're down in the hospital and you're like, okay, forgot what this all means, it's gonna be right in here. And you can just look at it and say, okay, I just saw upward and, let's say, left torsional and left Dix Hallpike, upward and left torsional nystagmus is lasting under a minute. That's gonna be called left posterior canal canalithiasis. Canalithiasis is free-floating crystals. So there's usually a little bit of delay. I always like to picture a snow globe that you turn over, and you're free-floating to the bottom. So there's a little bit of delay while the crystals drop, and then boom, you'll start to see that left torsional upbeating nystagmus, and it usually stops in a few seconds or under 1 minute. Free-floating in the canal, we call it canalithiasis. Whereas in cupulolithiasis, the crystals are stuck to the receptor site at the base of the canal, and it persists for over a minute, usually 1 to 2 minutes, but it does fatigue eventually. And that is called cupulolithiasis because it's stuck to the cupula. So not only do you have to figure out which ear it is and the nystagmus direction, then you have to figure out if it's a cupulolithiasis or a canalithiasis. And that's just based on the time. Is it short, canalithiasis, or is it longer, cupula? And the treatment changes a little bit with both of those. So for the left Dix Hallpike, if you see the canalithiasis, you're gonna do the epi or the Semant. You can do the Semant on either type of BPPV for the posterior canal. The Semant has been proven to be just about as effective as the epi. And the Semant can be nicer on the neck for people. There's 2 positions instead of 4. So we'll go through this a little bit also, but you can use either one of those for a canalithiasis. For cupulolithiasis, you're just gonna do the Semant, and again, we'll go through that. In the right Dix Hallpike, you would see a right torsional upbeating nystagmus going towards that ear. So let's go to some video. Okay, now, in Napa, you guys have the monocular view, one eye. Okay, this is the system that we had down here that we ended up getting the vestibular first goggles with the binocular, you can see two eyes here in Vallejo. But Vacaville still has the monocular view, Napa has the monocular view. So Jen, when you go, are you going to Vacaville? No, not yet. So when you go up to Vacaville, you might have to use these in outpatient. That's why I wanted to include these videos for you guys, so you kind of get used to. So I'm including both monocular and binocular, but someday we're all gonna have the vestibular first goggles and we can go all binocular, because it's much easier.
One day.
One day. Okay, so this is again more for Jen and Sean right now. I had to train everybody this way in the past. You see how the nose is here? Right, so this is on, the camera's on the left eye only. So you always have to, when you're watching these videos, you have to kind of reorient, okay, where's the nose? Now where's the head? So you have to make sure that you get the patient in the room camera when you're testing for BPPV. You have to know which eye you're looking at and where the head is. You did this to me.
We lost detector.
No. Why isn't it playing? It's playing. Oh, this is infuriating. Crap. Sorry, guys. Maybe we can kind of come around and look at it on the screen. Okay, see how her right ear's on the pillow? Her head's turned to the right, her right's ear on the pillow, so it's the right Dix-Hall pike. You guys see how there's a twist, there's a torsional component to it.
Yeah.
Okay, now we name the torsion, picture a pole on the top of the eye, straight line. Is it going, think about this, is it going counterclockwise or clockwise? And when I say it, I mean the fast phase of the nystagmus. So is it going quickly counterclockwise or quickly clockwise? Counterclockwise, very good. And you can even see the cornea, the whole thing is rotating to the right. And this is her right ear on this side. So this is right torsional nystagmus, and it's actually jumping up a little bit also. It's a little hard to see the upbeat, but if you look at the eyelid, a lot of times it will be helpful. You can see the eyelid jumping up. And any sort of vessels you can find in the cornea. See how our eyelid's going up?
Yeah.
So this is right torsional, upbeating nystagmus, and it lasts for only calming down, and it goes away. So under a minute, so this is right posterior canal thighs. This is how you document that. And then you do the right epilead to treat this one. Let me just see if the next one a little. Okay.
That works.
You can stay as close as you want to the screen, or go back to the seat, whatever you want. So this is the binocular view, right? Now you don't have to orient to where the nose is. One other huge point I want you to sink into your brains right now is in the videos, any of the videos you see where the patient's turning their head, like Caleb's like, okay, turn your head to the right and lie down. The patient's actively turning their head and actively lying down, you're gonna see nystagmus. So ignore the nystagmus while the patient's moving, that's normal. You have to wait until the head's down, and then you have to really let it settle and then analyze it. Don't worry about nystagmus during the patient's head moving. So his head's going down on his right ear. He's not getting anywhere near 30 degrees of extension because he's so stiff, and he gets the nystagmus right away. He's 30 degrees above neutral. Do you see how there's a rotatory component, and the quick phase is going towards his right ear, and his eye is jumping up a little bit. Is there anybody that doesn't see that?
No, I just saw extra in the beginning. It would just look like it was going up and up beating instead of torsional so much. We just that's what.
So then you saw it settle into kind of like the pattern, right? So you have to kind of really watch it, let it play out, and if you see some funky stuff in there, I saw a few horizontal beats. Okay, that settled. Now this is okay. Now that's all torsional upbeating. It's like just a 80-20 rule. What's the big picture that you see of the primary nystagmus pattern? There might be some superfluous beats in there. Just what's the big picture? So that one is also a right posterior canal physis. Okay, here's a monocular view again. So which camera is the eye on?
Oh,
We
it's
can't
not
see.
there.
We don't
It's
have
not
that.
up.
Oh, hold on. Actually, there's one.
Oh, there it is.
Right there, right?
Right eye, good. And this patient, Chad has him on his left ear. So you might say, is that just upbeating?
No.
Right, but if you
Just a
see-
little bit.
Yeah.
You see that little twist, right? And that's, the fast phase is going clockwise there. No. Yes?
Yeah,
Clockwise.
Yeah.
Yeah. So
Right.
that is
That's right.
left posterior canal, and again, it fades and it resolves under a minute. Left posterior canal physis. Everybody comfortable with that? Okay.
Can we use instead of counter and clockwise? Just gonna go right and left.
So, yes,
Yeah.
for you with the vestibular first, because it clearly says right, left, you see the nose. For Sean and Jen, if Jen is a nap and has to use those goggles, you have to be oriented to which way it's turning, because you can't see both eyes. That's the only reason I'm presenting it that way. Okay, that guy, see how his head is turned to the left? This is the left Dix-Hall pike, sort of. He's stiff also. I can't even get him down all the way. You see how much easier it is to determine, you don't have to see clockwise or counterclockwise with the binocular view. It's just towards the left or the right. So can you all see how there's a fast phase twisting towards his left ear, drifting back to the right, flicking fast towards his left ear, and there's a jump up in the eyelids. So left posterior canal physis.
No.
Okay, a cupulolithiasis is just the same exact pattern, but for over a minute. There's nothing different about it, except you might see it immediately right away when they lie down, instead of there being a little bit of a latency. But it's more of the duration that's gonna help you diagnosis. So, let's go through the Dix-Hall pike and the epley, and then we'll move on to horizontal canal.
Mm-hmm.